Welcome back to the deep dive. We've got a really substantial task ahead of us today. We're going to do a deep, comprehensive analysis based on your source material. It's this incredibly detailed, highly organized outline on eating disorders.
Yeah, it covers etiology, neurobiology, characteristics, management, specifically anorexia nervosa, bulimia nervosa, and binge eating disorder.
It really is quite encyclopedic.
It is. And our mission here, I think, isn't just to skim the surface, right? It's to actually decode this dense outline for you.
Right. We need to go beyond just reading definitions.
Exactly. We need to get into the underlying biology, explore what drives these conditions psychologically, and really synthesize these clinical notes into something clear, something memorable for you, the listener. We want to give you the deepest possible understanding of what's in these notes.
Okay, let's unpack this then. Let's jump right into the core science, the foundation. Before we start separating out AN, BN, BED, your notes highlight this fundamental biological link between them all.
That's right. The source material starts right there with the neurobiology.
And the initial core connection seems to be the role of neurotransmitters. The research cited here points to dysregulation in both serotonin and norepinephrine systems being linked to eating disorders generally.
That's presented as the chemical foundation. Mood, impulse, anxiety. These systems underpin the whole spectrum we're discussing.
So that baseline, that serotonin and norepinephrine link, it's foundational because it sort of explains a vulnerability.
Precisely. If you think about what those systems regulate, satiety, anxiety levels, impulse control, they're all critically impacted in these disorders. So it immediately pushes the conversation beyond just behavior.
Into biology, a predisposition.
Yes, into the realm of biological predisposition.
Okay, speaking of predisposition, let's move right into the etiology section of your notes. Starting with the genetic hypothesis, it suggests a pretty clear hereditary link here.
That's right. The genetic hypothesis basically suggests that some people are, born with a biological vulnerability, a susceptibility that might get triggered later by environment or stress or maybe cultural pressures.
And the notes mention possible chromosomal links.
Yeah, the research suggests that possibility, meaning the susceptibility, might actually be hardwired, in the genetic code.
The evidence you've got here seems particularly strong for anorexia nervosa, or AN. The sources note a higher prevalence of AN among sisters and mothers of those who have it.
That kind of strong family pattern, it's hard to just brush off as purely environmental.
Right.
When you see a condition popping up repeatedly among first-degree relatives, it really points towards a significant genetic component. And that's vital because it changes how you think about treatment. It brings in biological interventions, maybe pharmacological support, not just, say, family therapy.
It underlines that the person isn't just choosing this behavior. They might be up against something quite powerful biologically.
Exactly. Fighting against a strong biological undertow.
Okay, so let's dig into that specific biological vulnerability a bit more. The neuroendocrine and neurochemical foundations mentioned in your notes. They get quite specific here, distinguishing between what might be driving AN versus bulimia nervosa.
Right. So for anorexia nervosa, the notes point towards a potential issue with hypothalamic dysfunction. That's within the neuroendocrine system.
The hypothalamus, that's the brain's control center for basic functions, right?
Exactly. It regulates body temperature, sleep, thirst, and critically for us here, hunger and satiety cues, if that's not working right.
Well, the body's ability to even recognize starvation, let alone respond to it, is fundamentally broken.
Which explains how someone with AN can be critically underweight, but still not feel the need to eat.
It provides a biological explanation for that phenomenon, yes. It's like the body's internal thermostat for survival is just set incorrectly.
So if AN is linked to that hypothalamic regulation center, bulimia seems connected back more to those impulse control systems we mentioned earlier.
That's what the notes suggest. The neurochemical specifics for bulimia nervosa seem to circle back to that dysregulation in serotonin and norepinephrine systems being particularly central.
Which makes sense given the nature of BN. Well, yes, biaturia involves these episodic, uncontrolled, compulsive behaviors, the binging. So a failure in the systems that manage mood, emotional response, impulse control. It fits. The binge could almost be seen as this overwhelming response to emotional distress, maybe an attempt to self-soothe with food driven by that faulty neurochemistry.
Now, this is where your notes get really interesting for me. Binge eating disorder, DCD. Often it's framed mainly behaviorally, but your material connects it directly to specific measurable gastrointestinal issues.
Yes, physical digestive changes that seem to reinforce the behavior.
Okay, tell me more about that.
This is a critical point, and the notes detail three specific physical markers associated with BED: delayed gastric emptying, an enlarged stomach, and decreased cholecystic CK secretion.
All right, let's break that down. Delayed gastric emptying and an enlarged stomach. What does that mean physiologically?
Okay, so if the stomach is larger, physically larger, it takes more food to stretch it and signal fullness. And if gastric emptying food moving from the stomach to the intestine is slower, that food just sits there longer.
Which sounds like it should make you feel full.
Paradoxically, it seems that extended presence can sometimes inhibit the right satiety signals. So you might feel uncomfortably full, but not necessarily satisfied in a way that stops the binge.
Okay, and then add the chemical part.
Yeah.
Decreased cholecystic secretion.
Right. CCK is a key gut hormone. It's released when you eat fat and protein, and its main job is to tell the brain, okay, digestion's starting, you're full, stop eating now. It's like a biological brake pedal.
So if CCK is decreased,
then that brake pedal is faulty, or maybe missing altogether. So you've got the physical capacity for more food, enlarged stomach, food hanging around longer, delayed emptying, and a weak chemical stop signal, low CCK. It creates this powerful biological loop that really encourages continuing the binge.
wow, so it links the physical state directly to the compulsive behavior in BDE.
Exactly. It suggests BED isn't just about lack of willpower. There's a failure in the gut-brain communication pathway.
So pulling that together from the notes. ANN looks like a disease potentially rooted in hypothalamic failure and starvation, BN in neurochemical impulse failure, and BED involves a failure of that gut-brain axis, making the compulsion profoundly physical.
That's a good synthesis of the biological distinctions highlighted in the source material.
Okay, let's transition now. Let's do a deeper dive specifically into anorexia nervosa, moving from those roots to how it actually presents clinically based on your notes.
All right, so the formal definition in the source material for AN emphasizes two core things: an intense, debilitating fear of gaining weight and a profoundly distorted perception of one's body.
And it's crucial to underline that distorted perception isn't just vanity, right? It's described as a cognitive disturbance.
Absolutely. Someone with AN might look in the mirror, see a skeletal frame, and genuinely perceive themselves as overweight or needing to lose more weight. It's a fundamental break from reality regarding their body.
And these notes immediately link that psychological picture to the objective assessment criteria. The diagnosis of AER is strictly tied to a body mass index, BMI, under 17.
Yes, that clinical threshold is critical. A BMI that low signifies a level of malnutrition that's an immediate medical emergency.
Before we get to the physical consequences, your notes mention the historical context a bit, the psychodynamic influences. Early theories apparently focused heavily on family factors.
That's right. Historically, clinicians often looked at the family system. The notes mention theories pointing to complex dynamics, maybe high levels of conflict, or sometimes emotional avoidance or intense power and control struggles. The individual, often an adolescent, might feel quite powerless within that family structure.
And the home environment itself is often described as overprotective, yet also perfection demanding.
Yes, that combination creates this high-pressure situation. The idea was that the only area the person felt they could exert absolute control was over their own body and what they ate.
Okay, but wait. How do these notes reconcile that historical, psychological view, the family environment, the need for control, with the hard neurobiology we just talked about, like the potential hypothalamic dysfunction? Does it suggest the environment triggers a biological vulnerability?
That's really the key synthesis, I think, that emerges from pulling all this together. The current understanding, reflected here, is likely that the biological vulnerability, maybe that faulty hypothalamus or the genetic predisposition, is already there.
Oh.
Then, the environmental pressure, that overprotective, perfectionistic atmosphere, the feeling of powerlessness, acts as the psychological trigger. It kind of weaponizes food restriction, turning it into the individual's primary, maybe only mechanism for feeling in control in what feels like a chaotic life.
They try to control hunger, a fundamental drive, showing immense discipline.
Discipline and perfectionism, yes, but that relentless struggle for control spirals, leading to those devastating physical consequences. Your notes have an extensive, really alarming list.
Yeah, it's a catalog of systemic breakdown.
It really is.
Yeah.
And it's all driven by that core psychological trait noted: low self-esteem, where their entire self-worth gets tied exclusively to their body weight and their ability to restrict. The body, starved of energy, just starts shutting down non-essential functions.
We see things that seem designed to preserve core function, like amenorrhea, the stopping of menstruation.
Right, the endocrine system halts fertility. But some details are just stark illustrations of the body's desperation, like lanugo.
Can you explain what that is for our listeners?
Lanugo is this fine, soft, almost downy hair that starts growing, particularly on the torso, face, and back. It's essentially the body's primitive attempt to create insulation, like a layer of fur, when the normal subcutaneous fat layer has been completely used up for energy.
Wow. It's a sign the body's trying to cope with extreme exposure.
Exactly. And it connects directly to other symptoms like cold extremities, hypothermia, and a profound intolerance to cold. The body is desperately trying to conserve every bit of heat.
This conservation effort then hits the circulatory and renal systems hard. The notes list major cardiovascular risks: hypotension, low blood pressure, and bradycardia.
Bradycardia is a dangerously slow heart rate, sometimes down below 40 beats per minute. It's the heart trying to conserve energy. But over time, this constant energy deficit can lead to cardiomyopathy, the actual wasting and damage of the heart muscle itself. The heart becomes weak, inefficient, and prone to failure.
And some circulatory issues are visibly apparent. Your notes mention impaired renal function and acrocyanosis. What's acrocyanosis exactly? It's listed as bluish skin.
Right. Acrocyanosis happens because the body makes a survival decision. It drastically reduces blood flow to the non-essential peripheries, hands, feet, nose to keep warm, oxygenated blood concentrated around the core organs, brain, heart, lungs. So that bluish or mottled look in the extremities is a visible sign of crisis. The body is sacrificing the periphery to protect the core.
Beyond circulation, there were two other risks highlighted that sound incredibly dangerous, one immediate, one long-term.
Yes. The first is electrolyte imbalance, specifically hypokalemia, dangerously low potassium levels. This isn't just a symptom, it's an urgent, potentially lethal emergency. Low potassium disrupts the heart's electrical signaling.
Leading to?
It can cause severe cardiac arrhythmias or even sudden cardiac arrest. When a patient with AN comes in, checking and correcting potassium levels is an immediate priority.
And the second, the long-term consequence mentioned, is the high risk of fractures due to demineralization of bones.
Absolutely. The body is so desperate for energy and essential minerals that when deprived, it starts pulling calcium and other nutrients out of the bones. This leads rapidly to osteoporosis, even in young people.
So someone with a history of severe AN could end up with a bone density of someone much older.
Precisely, making them highly vulnerable to fractures that can cause chronic pain and disability long after they might have restored their weight.
Okay, shifting to management based on your notes pharmacology for AN. What medications are mentioned?
Well, the notes emphasize medication is really an adjunct to the primary treatments of weight restoration and psychotherapy. But specific drugs are used. Fluoxetine, Prozac, is identified as the preferred medication.
But with a caveat.
Yes, it's often started only after the patient has regained some weight, as it seems less effective in a severely malnourished state. The notes also list others, maybe for specific symptoms or co-occurring issues. Clomipramine, anafenil, cyproheptadine, periactin, which is sometimes used to try and stimulate appetite, and chlorpromazine, Zyprexa, an antipsychotic that might help with severe anxiety, agitation, or those distorted body image thoughts.
So the medication strategy really reflects that biopsychosocial complexity of AN.
It does, addressing different facets of the illness.
All right, so if anorexia is characterized by that rigid restrictive control, bulimia nervosa, BN, presents more like a cycle, almost a battleground of impulse, followed by desperate measures. Let's pivot and analyze BN based on your source material.
Right. The core of BN, as described in the notes, is this cycle. It starts with episodic, uncontrolled, compulsive, rapid consumption of large amounts of food, the binge. This often happens in secret, frequently triggered by intense emotional distress.
And that binge, that feeling of losing control, is then immediately followed by these compensatory behaviors. The goal is to undo the calories, right? These are the purging behaviors.
Yes, like self-induced vomiting or misusing laxatives, diuretics, or enemas.
But it's important to note, based on your material, that it's not only purging in that classic sense.
Correct. The notes clearly state that BN may also involve non-purging compensatory behaviors. Things like periods of fasting or engaging in excessive driven exercise. There's still maladaptive attempts to regain control or compensate after the binge.
Now, that psychological difference, the restrictive control of AN versus the sort of impulse failure cycle of BN, is mirrored physically too. Your notes stress a key contrast in weight.
Yes, this is a critical diagnostic distinction. Most individuals with BN are within a normal weight range.
Unlike AN, where being severely underweight is part of the definition.
Exactly. For AN, we use that BMI under 17 threshold. But for BN, people typically fall within the normal weight BMI range of 20 to 24.9. This means the immediate medical dangers in BN often stem not from starvation, but from the trauma and the electrolyte chaos caused by the purging behaviors themselves.
Okay, so the physical signs of BN we should look for, according to these notes, are really the markers of those chronic purging activities.
Yes, signs of self-inflicted damage. Probably the most memorable physical detail mentioned is Russell's sign.
Let's make sure we explain that clearly.
Russell's sign is basically scarring, calluses, or abrasions on the back of the hand, usually over the knuckles. It's caused by the repeated friction or scraping of the teeth against the hand when someone manually induces vomiting over a long period.
A subtle but pretty direct physical clue.
A very direct clue. And beyond the hands, the mouth itself suffers significant damage. The notes highlight severe dental erosion and caries cavity.
From the stomach acid.
Precisely. Repeated exposure to stomach acid just dissolves tooth enamel, leading to widespread decay, sensitivity, discoloration. It's often irreversible damage. And the stress affects glands too, leading to enlargement of the parotid glands, the salivary glands in the cheeks.
Giving the face a sort of puffy look.
Yes, which can, paradoxically, worsen the person's body image distress.
Now, your notes mention a really severe complication, particularly linked to chronic laxative abuse, vaginal or rectal prolapse.
It underscores just how physically destructive these behaviors can be. Chronic, heavy laxative abuse completely disrupts normal bowel function, puts immense strain on pelvic floor muscles, and over time can actually cause organs to slip out of place or protrude. It's a devastating consequence.
And all these purging methods, vomiting, laxatives, inevitably lead to signs of dehydration and acute electrolyte imbalance, right?
Absolutely. Which brings us back again to that potentially lethal risk of hypokalemia, low potassium. Purging behaviors can rapidly deplete the body's essential electrolytes.
And this physical distress often goes hand in hand with significant mental health issues.
Very often. The notes list common comorbidities. Depression, anxiety, personality disorders, and substance abuse are frequently seen alongside BN. The binging and purging cycle can become this incredibly destructive way of trying to cope with that underlying psychological pain.
Okay, let's move to the third main category in your outline, binge eating disorder, or BD. We need to give its distinct profile proper attention. The definition starts similarly to bulimia's binging part, eating large amounts of food, feeling out of control.
But critically, as the notes emphasize, without the subsequent compensatory purging behaviors, no vomiting, no laxatives, no excessive exercise afterwards.
And because there's no compensation.
The notes clarify that BED can result in obesity, which links directly back to that clinical BMI definition of obesity as greater than 30.
And thinking back to those unique biological markers for BED, we discussed the delayed gastric emptying, the low CCK. Does that mean the pharmacology is different too? Your notes list two specific medications for BD.
Yes, the approach is distinct. The two medications highlighted are topiramate, Topamax, and lisdexamfetamine, Vivance.
Topiramate. Isn't that usually for seizures or migraines?
It is, but it's also been found to help reduce binge frequency in BED, possibly by affecting neurotransmitter activity. And lisdexamfetamine, which is a stimulant, actually has specific FDA approval for treating moderate to severe BED. It seems to target the impulsivity and might also help with weight management.
So the medication targets the compulsive drive, reflecting those underlying biological factors we discussed earlier.
Exactly. It acknowledges the deep-seated nature of the compulsion in BED. Okay, so we've looked at the specific characteristics of AN, BN, and BED based on your notes. Now, we should probably consolidate how this material guides professional assessment and diagnosis, starting with those objective numbers.
Right, the BMI thresholds, they give that immediate snapshot. Let's just quickly recap those for clarity because they really frame the initial medical concern. AN is defined by that BMI of 17 or lower. Normal weight, where most people with BN tend to fall, is 20 to 24.9.
Right.
And obesity, often linked with BED, is defined as a BMI greater than 30.
So those metrics establish the physiological baseline, or the level of emergency. But the full picture, the diagnosis that really guides treatment, comes from identifying the complex psychological and physical distress. Your source material outlines key nursing diagnoses that kind of reveal this core struggle, the battle for the body versus the battle for the mind.
Okay, so on the psychological side, the notes highlight ineffective denial related to loss of control and disturbed body image, low self-esteem.
That first one, ineffective denial related to loss of control, is really profound when you think about it. It captures the paradox. The person denies how sick they are because the illness itself has become their main source of feeling in control.
So admitting the illness means letting go of that control, which feels terrifying.
Exactly. The denial is ineffective because it's ultimately self-destructive, but it serves a powerful psychological purpose for the individual at that moment.
Makes sense. Then the physical diagnoses listed reflect that urgent medical need. Imbalanced nutrition, which could be less than body requirements in AN or more than in BED, and deficient fluid volume, which is especially critical in BN with purging.
Yes, highlighting the dehydration risk. And then tying it all back to the emotional core, the notes mention anxiety related to feelings of helplessness or lack of control.
So what this all really boils down to, looking across these diagnoses, is that central theme again, control. Or rather, the feeling of lacking control and the desperate, distorted ways of trying to get it back.
Absolutely. Every aspect of the assessment, the denial, the body image issues, the anxiety, all seems to revolve around this deep-seated struggle for autonomy and a tragically distorted view of self. The illness becomes both a symptom of that struggle and the person's perceived solution.
Which brings us directly to treatment. If that struggle for control is the absolute core issue woven through everything, then understanding that has to be the key to effective management, right?
That's precisely what the source material emphasizes. It makes this crucial thematic observation. The central issue in eating disorders is control.
And that understanding directly shapes the clinical approach.
It has to. The notes explicitly state that treatment success is significantly more likely when the patient feels in control of their treatment, if the team comes across as just imposing rules.
It backfires. It reinforces the fear and pushes them back towards the illness as their only source of control.
Exactly. So the approach has to be collaborative, empowering, not authoritarian.
Okay, so how does that core principle translate into the specific, practical nursing interventions listed in your notes? What are the concrete steps for management?
Well, the strategies detailed are really about rebuilding stability, both physically and psychologically, while fostering that sense of autonomy. First and foremost, the relationship is key. Establishing a supportive, trusting relationship is step one.
And then the medical side.
Rigorous monitoring of vital signs, electrolytes, and intake output. That's non-negotiable medical surveillance to catch and prevent those acute dangers like cardiac issues or kidney problems.
But even the physical goals need that collaborative element.
Yes. The notes stress establishing realistic weight gain goals with the patient. They need to have agency, to feel ownership over their recovery path, even the physical targets.
And for NEN specifically, where control is exercised through restriction and maybe excessive exercise.
There, clear but compassionate limits are necessary. That includes setting limits on exercise to promote weight gain. For someone whose self-worth is so tied up in discipline, limiting exercise forces them to confront that dependency and find other ways to feel competent.
Okay, beyond the physical monitoring and goal setting, what about the psychological strategies detailed?
The notes point towards using behavior modification techniques. The aim is to help the patient develop effective, healthy coping strategies to replace the maladaptive one's restriction, purging, binging when they feel stressed or anxious.
And support systems.
Critically important, encouraging involvement in support groups is recommended not just for the patient, but for the family too. The whole family system often needs education and support to help the recovery process effectively.
So we need measurable outcomes, right? Not just feeling better. How do the notes define success? What does mastering that control issue actually look like?
Success is defined pretty clearly in terms of both physical and psychological stabilization. Physically, the goal is for the patient to achieve and maintain at least 80% of their expected body weight. Alongside that, vital signs and lab values need to be within normal limits, showing reversal of things like bradycardia or hypokalemia.
That's the physical stability. And the psychological side, the proof that they've found healthy control.
This is the ultimate aim. The patient will be able to verbalize ways to gain control over their environment to reduce those feelings of powerlessness. They shift from using the illness defensively to proactively managing their life.
So they learn new strategies.
Yes. And ultimately, the outcome is that the patient will demonstrate the ability to control their life without resorting to those maladaptive eating behaviors. That sustained behavioral change is the real evidence of having mastered that core psychological struggle. #outro.
Wow. This has been an incredibly detailed journey through your source material. We've covered so much ground from the genetic predispositions and those specific neurochemical links,
Hmm.
serotonin, norepinephrine, the hypothalamic issues, that faulty CCK signal.
Mm-hmm. All the way to the really stark physical signs like Lanugo and Russell's sign and those critical BMI cutoffs that define the immediate medical picture.
Yeah.
And I think if we connect it all back, the sheer complexity of these disorders really comes from that intricate, often painful mix of biology, the severe physical health impacts, and these deeply ingrained psychological needs, especially around control.
The goal here was really to give you, the listener, a thorough, comprehensive understanding of these detailed notes.
Exactly. By explaining the why behind the different mechanisms and symptoms, we hope we've managed to make this complex information more accessible and memorable for you.
Which leads us to maybe a final thought, something for you to mull over, drawn directly from the structure we've analyzed today. Given that control is this central issue, showing up as ineffective denial in one diagnosis, anxiety related to helplessness in another, how might that internal experience of losing control actually feel different?
Yeah, think about the difference between the restrictive, hyper-controlled state of anorexia nervosa versus the cycle of chaotic impulse in bulimia nervosa or binge-eating disorder.
Even though both might stem from that same fundamental struggle for control.
Right. Is the person feeling like they're failing at their discipline? This may be in BN or BED. Or paradoxically, are they succeeding too well at their dangerous form of discipline, like in AN?
It's a subtle but potentially important psychological distinction for how you might approach treatment and empowerment. Something to think about.
Definitely.
Thank you for joining us on this very critical deep dive into these essential and highly detailed clinical notes. We genuinely hope this comprehensive breakdown helps you master this complex material.